I'm Anjni Joyner. I'm an assistant professor at Duke University, and I work at Duke University Hospital in the emergency department. Duke University Hospital is a tertiary care center in Durham, North Carolina, and we have an 80-bed emergency department and see just about 80,000 patients per year. Our admission rate after COVID has been around 28 to 30%. Pre-COVID, we were around 25%. It is an academic institution, so we have the full cadre of residents and subspecialty services available.
Hello, everybody. My name is Yaffee. I'm an assistant professor of emergency medicine at Emory University, and I practice clinically at Grady Memorial Hospital as well as Emory University Hospital. Today, I'm going to be focusing primarily on my experiences at Grady Memorial Hospital. So this is our urban safety net public hospital in urban Atlanta, Georgia. So it serves the Atlanta metropolitan area of about 6 million people. And it's a very large urban emergency department. So we have over 150,000 annual patient visits, and we have about over 80 beds in our emergency department. I say over 80 beds because we have a lot of rooms, but then we have a very fluctuating hall spots in our ED, so we can accommodate all of our patients that we need to care for. Similar to what Dr. Joyner has said, we have historically admitted about 25% of our patients, but again, during COVID, that number went up a little bit. We have an average length of stay at our emergency department of a little bit over 5 hours and a left without being seen rate of 1%.
Oh, that's great. That's also interesting to hear because like your admission rates are actually quite similar to ours. So we would have so the city we're in is only 200,000 inhabitants, but we have a fairly large catchment area, and it's a lot of like countryside. And so we would have like 50,000 visits per year, roughly. Yeah, and admission rates would be around 27%, I'd say, pre-COVID. I think actually it has been fairly stable over the pandemic because we've seen a lot less of like common accidents, like road traffic accidents and stuff. So it has sort of evened out, but it's actually rising because people are getting back to doing stupid things while also catching COVID, unfortunately. So yeah, but it's interesting to hear because it's quite similar in that sense.
A common misconception or lack of knowledge of the interaction between attending residents and interns, because here in Sweden it's a little bit different between EDs, but generally there's quite a flat hierarchy where interns and residents manage patients quite a lot on their own and maybe just run through them with an attending.
Sure. I would say that we're probably a little bit similar in terms of the resident supervision. So for patients who are back in what we call the pod area, so once they've passed through triage and are in our general care area, the residents primarily manage them. Interns, first-year residents usually require a little bit more oversight than our senior residents. But essentially, the residents take ownership of the patient with supervision from the attending physician. Our triage area is staffed by attendings only. So we don't have any residents in that area. And the attendings will do a medical screening exam, which is kind of a unique thing to the US, I think, which is mostly due to EMTALA, which is the Emergency Medical Treatment and Labor Act, which requires any patient who is presenting to an emergency department to receive a medical screening exam. And so during this process, the attending physician will place orders, including labs and imaging, before either sending the patient back out into the waiting room or placing them into a room. And then we have a fast track area, which is staffed with attendings and physician assistants.
Okay, so basically most patients that you see are actually first screened by a senior physician, and some processes will have been initiated when like a resident takes over. Is that correct?
Correct.
Dr. Joyner, how is it? You didn't mention a lot about zones or like what happens when the patient enters from the waiting room or into the pod area, I guess.
Sure. So our system functions a little bit differently than Grady Hospital. We have a dedicated nursing position to place patients into different, we call them pods, but it's a similar concept to the zones. So we have a position called a nursing bed czar. And their primary role is to place patients and to ensure that rooms are being turned over quickly and that patients either presenting via EMS or via private vehicle in the waiting room are placed in the appropriate room. So they've kind of got tabs on the entire department at all times, both in our resuscitation areas as well as the medical pods. We also have a smaller psychiatric unit as well, which is comprised of 8 beds. And then a fast track area, which is 11 beds. And so the nursing czar will look at the patient's initial triage information, what available beds are open, and determine the placement of the patient, either in a medical bed or back into the waiting room if there are no beds available. And that is usually done in conjunction with the attending physician who is in the medical screening area or the triage area at the time. So if there's any question of the patient's stability or placement, then they will defer to the physician.
Okay. Yeah. So it seems like there is quite a lot of collaboration between nursing staff and the attending physicians in placing the patients in both of your settings. Is that correct?
Correct. Yes.
So we have a very skewed image of what is, I suppose, what's actually happening in your emergency departments. So it would be very informative if you could give us a couple of just examples of common crowding scenarios and sort of what's it like when it's busy? Because I suppose it's not only shootings and hurricanes.
I personally don't think it's that silly. Unfortunately, the U.S. has that reputation for very unfortunate reasons, and we do have a lot of gun violence that goes unaddressed, as well as other mass casualty incidents on a fairly regular basis. But I agree with Dr. Joyner that in general, we're not experiencing mass casualty incidents on a regular basis, but there is a very cyclical nature to our crowding. So at Grady, we see highest volume of patients presenting early in the week, like Mondays, Tuesdays, maybe Wednesdays in the afternoons. And then kind of towards the end of the week, we get a little bit fewer patients, and then we spike back up on the weekends with our trauma. So in Atlanta, we have a large volume of both blunt trauma from our highway system that runs straight through our city, as well as a lot of penetrating trauma. So we see a lot of gun violence on a daily basis, but particularly Friday and Saturday evenings are kind of our biggest time. And so we respond to that by our staffing and some other strategies. We also see a more monthly or cyclical kind of seasonal nature to our crowding. So over flu season in particular, aside from this year, which was like a totally obviously weird year, but usually during flu season, so like December, January, February, we see a lot higher volumes of patients presenting in the winter time.
And are your trauma patients, are they, secluded in the ED or separated, or is it run with the same staff as, because I imagine that with such a large center, you have quite a bit of trauma and possibly the ability to sort of specialize or isolate those type of patients.
Yeah, we have a dedicated trauma center. So it's a 15-bed trauma center within our emergency department. And so that's staffed by, it's still the same people that work throughout the rest of the emergency department, but on dedicated trauma days. And we work very closely with our trauma surgeons and surgical consultant colleagues in that area to take care of those patients.
So we are also a level 1 trauma center. We don't quite have the trauma volume that Grady sees, but we do have a pretty good knife and gun club in Durham. So we do see a lot of penetrating trauma and blunt trauma from the surrounding highways. We don't have a dedicated trauma area, but we have a dedicated resuscitation area. So we have 4 resuscitation rooms, which are dedicated for critical patients. So whether medical patients or trauma. So any penetrating trauma that is significant, meeting level 1 criteria, would be placed in a resuscitation room. Our surgeons are also on site. They are usually upstairs in other parts of the hospital, either in the SICU or surgical wards, but are on call. So when they receive a page for a level 1 or level 2 trauma, they come down to the emergency department to see the patients. They are not required to see patients for level 3 traumas within a specified time period, but for level 1 and level 2 trauma patients, usually the attending surgeon or attending trauma surgeon would need to be on site at patient arrival or shortly thereafter.
So, Dr. Yaffee, you told us that you have the beds, you have all the beds you need basically for the patients daily. I understand that's an exaggeration, but how do you know as an attending, because I guess you're working usually as an attending in one of the zones, how do you know when there's when there's crowding, and what's your definition of crowding when working as an attending at your place?
Yeah, I'm probably gonna get in trouble because I would say we are always experiencing crowding. Don't tell them I said that. So we kind of renovated our ED to have more beds about a couple of years ago now, and we were hoping that would resolve some of our crowding issues, but if you build it, they will come. So then our volumes just went up even more. And so we were trying to get away. Our old ED was a little bit smaller. We had a lot of stretchers in the hallways, and so we were trying to get away from hall spots, but unfortunately now we just have more hall spots. And they've become a little bit more permanent in that we've labeled them with letters so we can find the patients more easily. But yeah, I would say, it's a terrible feeling to know that there's critically ill patients sitting in the waiting room or sitting kind of on ambulance stretchers waiting to be brought back. And so with good intentions, most of our charge nurses and the paramedic dispatchers, the people seeing the patients at the front end, would prefer to bring a patient back into the zone to have eyes laid on them rather than have them in the waiting room or in the ambulance waiting area. So that leads to a lot of stretchers piling up in the hallway, kind of waiting for beds, and kind of some creative care spaces, as well as kind of quick rotation of patients in and out of rooms. So we try and deal with it that way, but we know when we're crowded by our length of stay in the waiting room generally. And that usually correlates, unfortunately, with lengths of stay in our hospital in general. So crowding is not really an ED only issue, right? It's basically a whole hospital issue. So when the hospital is full, then we can't get our admitted patients out of our ED beds. And so that leads to basically a lot of admitted patients taking up our rooms and taking up a lot of nursing care while we're trying to care for our new emergency patients in our hallways. So at some of the heights of COVID, we were boarding, 60 to 80 patients in our emergency departments waiting for beds in the hospital. So we tried to find new places to take care of them, some overflow spaces. The hospital kind of created some new wards, but in general, unfortunately, the burden of that usually falls onto the ED, which creates a lot of downstream consequences.
You have patients staying overnight in the ED even?
Yes, yeah, we have, and sometimes we had as many as 80 hours of inpatient time spent in the ED.
Yeah. Planning-wise, I suppose you can do some things about these cyclical patterns. Do you have any sort of adjustments in your schedule for for instance, Monday evenings or over the weekends, or how do you go about that? Do you have any strategies?
So we do. So we have additional staffing coverage, both physician as well as ideally nursing staffing coverage on our busiest times. So we have, like I said, an attending staffing all zones with resident coverage, but we also at some hours of the day have float attending coverage. So, and sometimes double attending coverage in our trauma center and some of our other areas. So Friday night, Saturday nights, we'll have double attending coverage in the evening time. And then we'll have the float attending during the day who can kind of flex to areas as needed, and also provide, there's, sometimes some patient some things we're asked to do, for example, like medical clearance of psychiatric patients, caring for our detention patients, some like sexual assault, the legal kits, they take up a lot of time. And so that person can then kind of take care of those type of patients. It's to allow the other attendings to staff the zones. One thing that creative thing that Grady has done for dealing with the seasonal changes is actually we bring in a mobile emergency department in our winter months. We call it Zone X. It's a mobile company that has about like 20 beds in it. It's like a big trailer, and it's kind of self-contained, and we can care for a lot of lower acuity patients in that zone. So at our height of our typical flu season, when we're seeing a lot of patients, we actually don't even have patients come into the ED. We just send them straight to that zone to be cared for and then discharged from there. So we have the ability to have some flexibility.
So I think you alluded to, Dr. Yaffee, that you monitored length of stay, or at least that was how you noticed. And do you regularly or automatically monitor like the average length of stay, or is it just that you notice that there is generally people staying longer when you look at the ledger?
Yeah, so we use, I think fairly universally in the US, we use a lot of different metrics to determine kind of like the success of our emergency departments. And so they're constantly monitoring that data. So like door to physician time is an important data point, ED length of stay, boarded patient length of stay, left without being seen, patients who elope after starting their care. Those are all kind of really important metrics, and we monitor them like kind of on a daily basis. And the nursing supervisors usually are giving us updates, and then we also, at our monthly faculty meetings, get an overall trend of what we were seeing in that time. And they use some of those metrics to determine if they're going to open up kind of creative care spaces, if they're going to call in overtime, offer overtime for nurses, that type of thing, to kind of flex to be able to care for our patients.
And are you getting those feedback in real time? So when or is it like the past 24 hours?
Usually fairly real time. So we often hear about our metrics at nursing shift changes. So the nurses change at 7 a.m. and 7 p.m. So at least twice a day. But then there's a lot of behind the scenes with nursing, actually. So the charge nurses and the nursing managers and kind of the bed team from the whole hospital have fairly regular meetings, like every couple hours while on shift, to kind of assess the overall situation in the hospital.
Would any of you guys in your scenarios have individual metrics on physician performance?
And for us, it's not as relates to overcrowding or these specific metrics. They're mostly emergency department metrics rather than individual metrics.
Yeah, we get like patients per hour, and then like RVU based on our billing per patient, that type of individual metric, but nothing for crowding.
How do you do, Dr. Joyner? Do you measure or what metrics do you use? Is it the same and as at Grady? And do you measure NEDOCs as well?
So yeah, it's a very similar system, primarily run by the charge nurses and the administrative staff during the hospital or who were in the hospital at the time. We do use NEDOC scores, and actually we're working on a project currently to develop a data visualization capacity decision support tool through the Duke Institute for Healthcare Innovation, which would allow us to appropriately utilize diversion. So I'm not sure if ambulance diversion is common in Sweden, but it's something that we run into fairly frequently here in the US and in our system as well. In our county, we have two main emergency departments, Duke University Hospital and Duke Regional Hospital. And they usually communicate pretty frequently between the two hospitals to determine if one is going on diversion, making sure that the other one is not on diversion so that we don't cause a lockup in the county. So we're working on developing a decision support tool for patients where our ambulance providers or ambulance personnel would be able to provide a gauge of hospital capacity to the patient in order to determine where the patient would like to go. So if they were originally planning on going to Duke Regional, they may change their mind and decide to go to Duke University if Duke Regional appears to be very crowded at the time. So that's a tool that's just being started to be developed, but it will hopefully aid in decision-making and put a lot of the onus on the patient and providing the patient with the appropriate data that they need in order to make an informed decision.
That sounds very interesting. But would that only be the first stage for EMS patients, or would it be to any patient?
So just for EMS patients at this time, because it's specifically meant to address ambulance diversion.
Mm-hmm. Okay. Yeah, but I guess I guess you could see that, using an app and deciding, oh, I'm going to the emergency department, which
Absolutely.
should I go to, based on diversion status, for walk-ins
It's a
as
great
well.
idea. I don't know if that's been explored yet, but it is an interesting idea.
Do you have anything you feel that you want to mention that you haven't had the opportunity to mention?
I think one of the strategies that we've tried to take in order to address overcrowding is trying to be aggressive in seeing patients in non-traditional spaces. And that's something that I've encouraged our residents to do as well. So if there's an empty triage room and a waiting room full of 40 plus people, maybe if you're scanning the waiting room board and you notice that someone has all of their labs back, that they're in easy disposition, ready for discharge or admission, trying to see that patient in a triage room and getting that disposition done so that they're avoiding another 2 or 3 hour wait in the emergency department. So that's something that I would like to encourage our residents to do. And I'm not sure if that is a model that would work similarly in Sweden as well.
It definitely would. Definitely.
Yeah, I would say kind of my 3 biggest takeaways from thinking about ED crowding. Number 1, being really flexible and creative, like Dr. Joyner said. So thinking about other places to see patients, kind of other ways to take care of them. Number 2, realizing that it's not a ED specific issue and we shouldn't be functioning in a vacuum, but really this is a healthcare system issue and a hospital issue. And so the more that we have buy-in and conversations with our administrators and other services, working through creative ways to handle some of our choke points, I think is really important. And we should never be just the only ones thinking about that. And then number 3 is just really being transparent with patients. So we had one of our medical directors who was very beloved, just left to a new position, but he always said, under promise, over deliver, go tell those patients it's going to be 6 hours, hopefully it's only 5, things like that. And then also just making sure that you're really talking to patients about their expectations for their visit, but also the fact that, if you wanted a CT scan as an outpatient, that's going to take you 2 weeks. We're going to get it to you today. It may be 6 hours from now, but it's at least going to save you time in the long run. So the way you kind of couch it and the way you have those conversations with patients can also help manage those expectations. And then sometimes, we don't do this at Grady, but at Emory University Hospital, we have a patient advocate who actually works in our waiting room. And so he'll kind of check in with patients. If there's grumbles of dissatisfaction, he'll be able to kind of address some of that. He'll bring people blankets or juice, kind of small things to help make their stay a little bit more comfortable.
Yeah, so number 1 tip, same as Dr. Yaffee, trying to be aggressive in seeing these patients in non-traditional spaces. 2, I think it's really important to remember that in emergency medicine, we function as a team, and working together with your attending and with your nursing staff and trying to expedite patient dispositions as best as you can, dividing some of the grunt work, like preparing discharge paperwork, making phone calls, I think really goes a long way when you think about the overall stay of the patient. And then 3, remembering that there are often really sick patients in the waiting room, and trying to reevaluate those patients as frequently as possible as you're allowed to, and checking up on labs that were ordered in triage to ensure that you're not missing anything critical for those patients that are still waiting for beds.